2004. So it's Mr. S, 20-year-old gentleman from Jharkhand. Since 12/6/24, presented with giddiness for 4 days, associated with lightheadedness, head spinning sensation, and vomiting for 2 days, which is 3 episodes per day, non-bilious and non-projectile. Had no loss of consciousness, no fever, no devolution, no altered sensorium, or no bowel and bladder incontinence. There's no history of decreased urine output, no over-the-counter analgesic use, no history of exposure to heat or excessive excretion, no history of exposure to pains or heavy metals, no history of CAM intake, and no history of fallout trauma. Past history wise, is a known shisha disorder since 2014 on oxcarbazepine 300 mg daily. He was recently diagnosed with hypothyroidism, has taken few doses of L-troxin. No prior surgeries or other hospitalizations. So he went outside for evaluation on 12/6. He was evaluated in the local hospital and told to have this AK, a kidney injury, and said he needs a dialysis. The outside reports on 12/6 show total counts of 16,900, HbA 16.2, urea is 126, creatinine of 8.47, sodium of 126 with potassium of 6.7. He came to our ED on 15/6. So an examination in our CMC, the respiratory vitals are all stable. There's no thyroid, no goiter. The systemic examination wise also, there's no significant findings. So this is on examination. This is one of the clinical finding which was seen. Can anyone tell what is this sign is? Actually, this is taken after 2-3 days after the treatment was started, so it's exactly null. So it's a Oldman sign which was positive in this patient. So summarizing, Mr. S, 22-year-old patient presented with nausea and vomiting with outside diagnosis AKA. So recently diagnosed hypothyroidism with positive Oldman sign. Since 2014, known seizure disorder in AED. There is no further seizure episodes. So what we considered for this severe non-oliguric AKA differential was either drug or NSAID induced, depletional, or heat stroke related rhabdomyolysis, or could it be a severe hypothyroid related? So the investigation showed a serum electrolytes of sodium of 124, urea was 159 with creat of 3.17, which is on done on 16, and protein of 9.1, and SGOT is elevated more than SGPT, involving suggestion of a muscle injury. And his urine routine also showed a blood of 3+, and his CPK was 14,718, suggestive of a diagnosis of a acute rhabdomyolysis. So on further evaluation, his TSH was 294, and he had an outside report of TSH showing 465 after he was started on hypothyroid L-troxin for a few days. He has taken few doses, and his T4 and FTC is on the lower side, and antithyroid antibodies were also positive for him. So the diagnosis made a diagnosis of rhabdomyolysis with acute kidney injury due to severe primary hypothyroidism induced. So coming to the causes of rhabdomyolysis, non-exertional, non-traumatic causes includes alcohol recreational drugs, electrolyte abnormalities, or endocrine disorders like hypo or hyperthyroidism or hyperglycemic states, and toxins related, and hypo or hypothermia. And non-exertional traumatic causes like compartment syndrome, crush injury, arterial injury, infections and immobilizations. And exertional acquired includes hyperkinetic state, seizures, and other genetical causes. So the pathophysiology in hypothyroidism induced rhabdomyolysis, there's no clear exact mechanism, but the hypothesis mechanisms are impaired mitochondrial oxidative metabolism, which causes reduced efficiency in mitochondrial energy production, leading to muscle weakness and damage. Induction of insulin resistance state. Thyroid hormone deficiency may induce a state of insulin resistance, which can affect the muscle metabolism. So decreased muscle carnitine levels, which leads to impairing energy production, and autoimmune mechanisms and abnormal glycogenolysis are all other proposed mechanisms for hypothyroid induced rhabdomyolysis. So there are some case reports which says hypothyroidism associated rhabdomyolysis and acute kidney injury. In this case report, this hypothyroidism associated with acute kidney injury. In this graph, as you can see, the patient initially presented with a creatinine of 4.4, with a TSH of 60, with a treatment with for hypothyroidism. With over a 4-month period, as his TSH has come down, his creatinine is also reduced. So another case report showing hypothyroidism induced rhabdomyolysis. As you can see in this picture, the initial creatinine on day 1 was 7.6, which on day 30 is reduced up to 3.4, and his TSH was initially 486, which was reduced with treatment is gradually reducing to 56.6, and SD and creatine phosphokinase was 8,770, which was reducing, and on day 30 it was 160. So with the treatment with the increase reduced TSH, the rhabdomyolysis KK is resolving. Another case report hypothyroidism induced rhabdomyolysis. In this also, the creatinine kinase on day 1 is 21,000, and the 6-week follow-up is 6085, with TSH more than 100, reducing up to 34. So the management wise, aggressive hydration for rhabdomyolysis till the CPK reduces, and monitor and treat the electrolyte imbalances, and the thyroid hormone replacement therapy with levothyroxine. So our patients were treated with aggressive IV hydration for rhabdomyolysis, and we started on levothyroxine 75 micrograms. And day 5 of treatment is creatinine has normalized to 0.98 and CPK has reduced to 1,168. The patient was clinically stable throughout. So the learning points is a Volkmann sign, a clinical sign to suspect hypothyroidism. A case of hypothyroid is a cause for rhabdomyolysis and AKI.
Can I ask something? Can you just go to the first slide about how did the patient present to the ED?
Giddiness, vomiting.
Vomiting, giddiness. So usually we don't think of hypothyroidism as a first thing,
Yes,
isn't it? Now this patient had a thyroid function test done outside.
Yes,
and you're saying it's autoimmune. Okay.
Yes.
Do you have done any other autoimmune workup to rule out it's
Yes.
not a?
We did autoimmune workup. Autoimmune workup was negative.
Do you do serum cortisol?
Serum cortisol was done. It was normal.
Because there's some hyponatremia and some potassium is okay. Somehow it's very rare to get such a rhabdomyolysis to be seen with hypothyroidism. Did he have muscle weakness?
No, ma'am. No obvious. Not much obvious weakness.
He was referred for actually management of AKI. The cause of AKI presenting was acute rhabdomyolysis. In hypothyroidism, they are present with a severe acute rhabdomyolysis like he presented.
His T4 was lower.
So that was here.
Yes.
Sorry, this is 0.4. T4 is 2, I think. Yeah, so what is his occupation? What's the occupation?
This is 28-year-old.
Occupation. What work is it?
Like,
So is it possible that he just had a heat stroke and this is just a fever?
but he didn't have no fever. No, not good.
There's no fever.
No fever.
It's not like.
The rhabdomyolysis cause of rate of 8 is too.
Yeah, outside was 8.
Outside 8, ours is 4.
But maybe they also had 8 in them, I guess. He had the rhabdomyolysis, which was maybe the only condition isn't the hypothyroidism that caused the.
No, it's something like a autoimmune myositis. Something else also is happening.
So we
We did have
other
autoimmune.
causes of rhabdomyolysis. It was negative. Most likely hypothyroidism with levothyroxine supplement it actually increased. We reviewed drugs for statin and other things.
No muscle weakness.
No, so this was not like a hyperthyroid myopathy. I think in there the CPK is never more than 5%. Yours was very high. This was like a
Did he have any symptoms of hypothyroidism before? Like, did he have any weight?
He's not particularly gave up any symptoms regarding. He didn't give any symptoms regarding.
Any other medication or?
Yes, sir. We went to the other drugs. No, sir. Only is oxcarbazepine, but he's been on since 2014. He's been on for 10 years on this drug.
Even hypocortisolemia can start.
Yes, he took a few doses, some 3 to 4 doses. Like that outside report of 465, he took some 4 doses.
Sometimes when you start L-toxin supplement and there's a hypocortisolemia baseline,
We
you
are also
can-
working on a mixed edema.
you should write as a case report, and I don't think it's very common to see this. Thank you.
Thank you.
Shall we go to the next one? By medicine 2, brightness is presenting the half of it.
Right.
Sorry, I saw brightness. Sorry, brightness is presenting.